You're listening to Fast Facts Perio Edition. And now, here's your host, Katrina Sanders.
Hello, and welcome to Fast Facts Perio Edition. Hello, and welcome back. And I know you all wanted me to bring her back for part 2. Here she is, the RDH, the incredible Kristin Evans. Kristin, thank you so much for coming back. I'm telling you, part 1 was a hit. Everybody's loving it. This conversation about saliva and pH. So here's what I'm going to say for all of our listeners right now. If you have not listened to part 1, pause, go back. Start by listening to part 1 because it is going to make you salivate. See what I did there? To join us for part 2. Okay, so let's continue this conversation. We started last week looking at some of the foundational basics about saliva and pH. And you mentioned at the end of part 1 about how you integrate this with your patients, how you screen, how you functionally address these salivary dysfunctions with your patients. So let's start at the beginning. Kristin, walk me through, how do we begin integrating the assessments, the screening, identifying those patients, and really walking them through the levels of care they need to address their salivary concerns?
Yes. So again, I love talking about saliva and pH because it is just not something that's really on a lot of hygiene radars, especially when we're talking about perio. And unfortunately, it is not on our health history, or we aren't talking about this on our looking at it, our health histories, and seeing the connection to pH, things that can matter to that, to finding out what is causing our patients to have more perio or to have a lower pH in their mouth. So I think what's really important is to be the detective as the hygienist, and that comes with the health history. So we have to do those screenings and talking to our patients. We have to get in and talk to our patients about what they're doing, the things that may be contributing to a lower pH, a generalized oral lower pH, because that's going to affect and get that environment, as we talked about the first episode. It's going to create that environment that's conducive to the pathogenic bacteria. We don't want that. We want healthy bacteria, and we want to make a more alkaline pH. So we have to talk to our patients and find out, are they contributing to this lowering of oral pH in their mouth through their diet, but also through immune system. Like we start to talk about their meds, or I always ask my patients, who are the other medical professionals you are seeing regularly? If they say a cardiologist, or they say an oncologist, or they say they're going to an endocrinologist, you know that they're having effects in their immune system. There's things that are compromising their immune system and weighing things down. And we can see that also in their meds. So these are big things that we can screen for to see where our patients lie. Like, are they a higher risk or not? And if we're not asking those questions about, instead of just saying, is there any changes in your health today? No. Okay, let me start scaling away. That's how it all happens. I hear it. I know that happens in every dental practice because some of us feel like there's a lot of time, like we've got to do too much. But you have got to take care of the patient. If you find out a few little things, you can always talk about them while you're scaling. You just are collecting information. So big one is medication updates. And if they're on 3 or more meds, they most likely have dry mouth. But I also ask my patients now, do you ever have dry mouth? Do you have sleeping problems? Do you snore? Those are all things that are going to cause a low saliva flow. And we know when low saliva is, when our saliva isn't flowing, which is the lifeblood, that's again what I talk about, it's the lifeblood of our oral cavity, our oral health. If we don't have that saliva flow rate, then we're going to have a lower pH. And that's, again, conducive to the bacteria, and the bacteria are also contributing to that pH. So we have to do that. We need to talk about those things that are really important about medications, who they're seeing regularly, some of their health concerns that they're dealing with, and then we can bridge that, bring them together, which is my favorite thing to do, is bridging the gap between mental, physical, and oral health.
I think this is amazing. And you are spot on. It's always so fun. This is what I love about episodes like this, because once you hear it and you bring that awareness to it, then it's like, oh my gosh, then you start looking in the mouths of your patients so differently. So while you were talking, I had to pull this data up because I remember I talked about it in a deck, and I know you talk about this all the time. So your research may be a bit more updated than mine, but a meta-analysis that was done in 2018 looked at the prevalence of Americans who suffer from dry mouth. And at that time, this meta-analysis showed that about 27%, so that's over 1 in 4 of your American adult patients are going to be experiencing dry mouth. And more specifically, okay, this is the crazy thing, because we all remember from pharmacology that, with the exception of like pilocarpine, everything dries the patient out. Well, the current statistics right now indicate that almost 70% of our adult Americans over the age of 45 are taking at least one prescription medication. So the reason why this is so important is because I think as hygienists, we become so calloused to seeing disease. I mean, how often do you actually see a patient who has a pristine health history and perfect vital signs and no chief complaint and gorgeous salivary flow and amazing resilient hard tissue and perfect gum tissues that don't bleed when you touch them, and a gorgeous airway with tonsils that are like, it's all good, we'll hang out of the way, and a uvula that just like goes up to the palate the way it's supposed to, and a TMJ that functions perfectly. And it doesn't, we don't see, at least I don't know. I work in Perio, so that's like a dream
we
come
don't see
true.
that.
Okay.
Yeah, I'm in a general dental practice, and there is probably not one, including hygienists.
Right.
If you take one med, and let me list some of the meds that cause dry mouth, and many of you, antihistamines. Hello, it's allergy season.
Allergy season.
High blood pressure med, pain meds, especially opioids. We have an opioid problem, and also NSAIDs. Then we have Parkinson's meds. Those aren't so common, but still. And then we had those that are sedation meds for like sleep issues,
and
muscle relaxer. And you know what? Number one that causes it is antidepressants. And we're seeing more of that. I'm very passionate about mental health and hormone health and the menopause in women. And I speak on this, and it's big in my life. And this one med can make a difference in a patient with salivary flow, which means what? pH drop. We never can get that Stephan's curve. The natural healing ability of the body is compromised. Now, what are we going to do about it?
There you go. And it is important to know that because, oftentimes I think we even are so focused on asking the patient, any changes to your medications. And I think we miss even, are you changing the dosages of your medications, which can have an influence on that? Or sometimes patients will say, oh, I'm taking a blood pressure med. Well, when you really deep dive into it, now they're taking multiple blood pressure medications to try to target that. A few other things that can contribute to dry mouth, though, beyond that is aging. So, gosh, our patients that are aging and their eyes are getting drier and their skin is getting thinner and their, saliva concentration or flow is dropping, cancer therapy, autoimmune disorders or diseases, tobacco habits, alcohol usage, even
marijuana.
That's right.
Along with tobacco and vaping.
Absolutely.
That hasn't been studied enough, but let me tell you, that's huge right now. And it's in our younger children. So we're going to start seeing that.
Which is so crazy because I think for a long time, when we think about xerostomia, dry mouth, some of these oral conditions, we kind of assumed this would be a more mature patient population. But gosh, now we're seeing it in our young people, even things like CPAP usage, orthodontic aligners, nerve damages, things like that. I mean, all of these things contribute to or can exacerbate some of these complications. So,
and autoimmune diseases, which are huge and more common in women. So when you have a woman come in, you need to be thinking about that, because women, and also menopause, I mean, all these things create this environment that is going to create a saliva flow decrease, and pH will also go with it.
So you screen them on the medical history side. What other things are you maybe doing clinically to evaluate concentrations of salivary flow, pH? Like, what are some of the things that you have on your tray or some of the things that are added inside of your questionnaires?
So one of the things, definitely I for sure ask them about their own saliva, because they are the ones that are with themselves all the time. And many times they will say, you got to figure out why they're dry, but a lot of them have sleep issues, and then you're going to go into that, right? So that's a big question. Now, most dental offices do not have the ability to do like saliva testing and stuff, but you can do saliva pH testing, and it's pretty easy. You just have to make sure that they haven't eaten, in the last 15 minutes, and that their saliva flow rate could be lower if they're nervous. So that is a hard one. So I like to have my patients actually do that at home. I like to have them do it during the day. It's kind of like taking your blood pressure when you're worried about a patient. You're like, could you just take it more often so we could get a kind of a baseline of what you're like all, during the day. And so I actually really like that. You have to kind of work with what we're doing. And I educate my patients, no matter who they are, on what to do to help their saliva flow, because everybody needs this, not just those who have a lower saliva flow.
I love that. And I love that you even bring up doing the litmus test at home, because to your point, your salivary flow is a vital sign. It goes up, it goes down, it goes up, it goes down. And it is a marker that tells us a lot of information about, our acidic levels and the different types of immunoglobulins and microbiota and all that good, yummy, juicy stuff. So it does ebb and it does flow. And there you go. It flows. And I think inside of that, it's important to understand, components throughout the day. You had previously mentioned, for example, if a patient tests their saliva pH first thing in the morning, this could help us identify a potential underlying acid reflux condition. Like this is
which is usually silent.
Right.
I mean, we have to, in fact, saliva flow rate people don't actually get xerostomia. Now, xerostomia is actually a patient actually feeling dry, but that doesn't have to do with hyposalivation. Hyposalivation can be way before that. You have to have 40 to 50% lower saliva flow before you actually get xerostomia. So patients who are actually feeling that, they're at a more critical point when you're actually feeling it. So this is a silent thing, along with GERD. GERD is silent. Like 80% of the people don't know they have it. And the same with, I think there's a huge misdiagnosis in hyposalivation or xerostomia, because they say it could be from 5% to 65%. That's a huge gap. So
yeah. Well, I mean, it even goes into, I'll share, I practice here in sunny Phoenix, Arizona. It is, 112 degrees outside right now. I mean, it is so warm. So anywhere you go in Arizona right now, as of the recording of this episode, we're in the summer months right now, but anywhere you go in Arizona, they're offering, bottles of water and things like that for people that, sometimes we can even turn that off and go, oh no, it's hot out. That's why. So we even justify in our own heads some of these complications. And I think it was so enlightening to share that really our job as preventive specialists is to dive further into that and to really understand, by the time the patient can feel it, they've already experienced so much in the way of a decline. And we know how incredibly vital and important our saliva is. So thank you so much, Kristin, for your incredible insights here. This was amazing. Thank you, the RDH, for unpacking how important saliva is to the true story. This has been another episode of Fast Facts, Perio Edition with Katrina Sanders. Please feel free to reach me on Instagram at The Dental Wine Genist or on my website, www.katrinasanders.com. Cheers.